I wish it did work. I really do. I mean,
welcome to the Strokecast. A Generation X stroke survivor explores rehab, recovery, the frontiers of neuroscience, and how to peel a banana with one hand.
Hello, I'm Bill Monroe, and welcome to episode 48 of the Strokecast. This week's topic is hyperbaric medicine. Stroke recovery is a marathon. It's not a sprint. Regaining cognitive skills, physical skills, sensory skills, and more, it takes time and it takes work. And during that time, life can be really hard and unpleasant for many folks. I'm sure that comes as no surprise to the survivors and caregivers listening here. Survivors may or may not be able to work. Relationships will get turned upside down. And after a while, you just want all of this hassle to go away. Surely, with all the advances in medicine, there must be something, some fancy technology or machine, some magical technique that will fix these problems, right? You see, that leads folks to look for and explore alternatives. And alternatives can be great if they work. Unfortunately, that also means that many survivors start pursuing things that don't work. Hyperbaric oxygen therapy appears to be one of those therapies. In hyperbaric oxygen therapy, the patient spends time in a pressure chamber where the air pressure is 2 to 3 times normal and breathes pure oxygen. That means they get roughly 8 to 12 times as much oxygen in their blood as they do in their normal lives. This, supposedly, should grow new blood vessels in the brain and revive dead neurons that were killed by the stroke, or drive new growth through neuroplasticity. I saw a number of people asking about hyperbaric oxygen therapy through Facebook groups and Twitter feeds, so I began talking with folks to learn more. Strokecast regular neurologist Dr. Nirav Shah introduced me to one of the world's leading authorities on hyperbaric oxygen therapy, Dr. Mike Bennett in Australia. This week, I talk with Dr. Bennett about the theory and the research around hyperbaric medicine. We answer the key questions about it. Is it safe? Does it work? The short version is that it is mostly safe, but there is no reliable research demonstrating that it works. The main risk is still to the patient's wallet. Keep listening as we explore the therapy in greater detail, discuss the challenges in conducting research, and explore things that can actually be treated with hyperbaric oxygen therapy. But first, let's learn a little bit more about Dr. Bennett. Professor Bennett is the academic head of the Department of Anesthesia, a senior staff specialist in diving and hyperbaric medicine at Prince of Wales Hospital, and conjoint professor in the Faculty of Medicine, University of New South Wales in Sydney, Australia. He graduated from the University of New South Wales in 1979 and spent his early postgraduate training at the Prince Henry Prince of Wales Hospitals before undertaking training in anesthesia in the UK. He returned to Sydney in 1990 as a retrieval specialist on the Lifesaver helicopter, and here developed an interest in both diving and hyperbaric medicine. He also has a strong interest in clinical epidemiology and is an experienced clinician and researcher. In 2002, he was the recipient of the Binky Award for Outstanding Scientific Achievement from the Undersea and Hyperbaric Medical Society. Since 2004, he has been highly involved in the teaching of evidence-based medicine within the medical faculty at University of New South Wales, and in 2005 was appointed co-director of the Quality Medical Practice Program there. He is the author of over 150 peer-reviewed publications, including 15 Cochrane reviews of the evidence in diving and hyperbaric medicine. Professor Bennett was the convener of the Australia and New Zealand Hyperbaric Medicine Group introductory course in diving and hyperbaric medicine from its inception in 1999 until 2014. He is an executive member of the Australia and New Zealand College of Anaesthetists Special Interest Group in Diving and Hyperbaric Medicine, chief examiner of the ANZCA Certificate in Diving and Hyperbaric Medicine, and chair of the ANZCA Scholar Roll Subcommittee. He is a past vice president of the UHMS and currently the past president of SPU-MS. So now, let's hear from Mike. So Mike, thank you so much for joining us on Strokecast this week.
Great pleasure, Bill.
Have you always wanted to be a researcher?
Good question, Bill, and the answer is a definite no. I did medicine, did some training both here and in the UK, in Britain, and eventually became an anaesthetist. An anaesthetist is an anesthesiologist, I should say, given your audience over there. Anesthesiology is a very social kind of field. We get to meet lots of people around the hospital. And one of the things I became aware of was the field of rescue medicine. And so I spent a while working on rescue helicopters using my anaesthetic skills to, provide roadside care. And that led me to coming back to Sydney, in fact, to the hospital that I trained at as a medical student and young doctor. And there happened to be a very sophisticated hyperbaric medicine setup. And while I was slowly changing my allegiance from rescue medicine on the helicopter to being drawn to hyperbaric medicine practice, it became clear that the great need in hyperbaric medicine was for clearly stated and understandable clinical research. And that's led me down that research path that you've mentioned. Since about the early 90s, I guess I've been concentrating about half on research and half on clinical medicine.
There's a couple of really interesting things in there. First of all, I really like how, I guess that's an Australian thing, is referring to it as rescue medicine as opposed to emergency medicine. There's just sounds like there's something more reassuring about rescue versus emergency.
Sounds more exciting, doesn't it? Well, I guess we use that term to distinguish it from the practice of emergency medicine, in emergency departments in the ER. When we say rescue medicine, we mean a service usually based on access with a helicopter, where you can retrieve people from remote and difficult locations who may be injured or unwell. And so while we did a lot of transfers from one hospital to another, the real reason everybody wanted to do that job was to pluck people out of the sea or out of the mountains where they were in trouble. And that's truly the rescue part.
Definitely going to be a different thing every day in that job.
Well, we had a lot of flights over Sydney over the years. So it was very rewarding and exciting, and I have to say, Bill, a young man's game. For most of us, there came a point where you say, well, how many times can I rappel or winch out of a helicopter into a dangerous situation and continue to get away with it? So just speaking personally, rather than getting, much more blasé and less worried about my own safety, I kind of got moved the other way, and I suspect I'm not the only one. And after a while, you think, for my wife and the rest of my family, maybe this is not something I should continue to do indefinitely.
So, it definitely, makes sense how that sort of shifts then into the hyperbaric medicine. But what exactly is hyperbaric therapy?
Yeah, that's a great question because it's much misunderstood. I would say that the best way to think about it is that hyperbaric therapy means any therapeutic procedure where the central therapeutic agent is pressure, breathing some kind of gases at pressure. That is pressure above the normal air pressure that we and all your listeners are breathing as we speak. And to receive hyperbaric therapy, you need to be in an airtight vessel which is capable of having that gas pumped in so that the pressure rises inside and you get the benefit of the breathing gas. But the problem with leaving the definition there is that what I and legitimate hyperbaric physicians practice is hyperbaric oxygen therapy. And that means, as the name implies, that we don't just deliver high pressure air, but we deliver 100% oxygen to breathe at pressure. And for practical purposes, I mean pressures usually between 2 and 3 atmospheres, so 2 and 3 times the normal air pressure. And it's that really high intake of oxygen into the bloodstream that causes the therapeutic effect. I guess what I've implied up to now is the problem with hyperbaric therapy, in which you don't use 100% oxygen, is that there's no proven benefit of therapy unless it is 100% oxygen at about those pressures. So your listeners could find centres all over their cities and towns that would deliver what they call hyperbaric therapy, which is just mildly pressurised air or maybe a little bit of extra oxygen. But it's nothing like what I'm going to mean as we go on when I talk about hyperbaric oxygen therapy. The only thing it has in common is that you need that vessel to increase the pressure.
What's really striking about that idea of going to 100% oxygen is something most folks don't think about a lot of the time, is that the air we generally breathe is, generally it's about 22% oxygen, and the rest is nitrogen and a bunch of other stuff. So we're really taking all that other stuff out, putting in more oxygen, and then pushing it in a lot harder is my understanding.
That's a pretty good way of putting it. So you're absolutely right, 21% or so of oxygen in the air. And if you breathe that at, let's say, 2 atmospheres absolute, which is twice as much pressure as we're both breathing now, then you get a little extra oxygen because there's twice as many molecules of oxygen as there is at 1 atmosphere. But really, that amount of oxygen would be easily exceeded just by breathing a few litres a minute from an oxygen tank with a mask. So you don't need the pressurization to get that much extra oxygen. What we do that's impossible any other way is breathe 100% oxygen at pressures above 1 atmosphere. And the only way to get that much oxygen into you is to have one of these pressure vessels, hyperbaric oxygen chamber, we usually call them. And the consequence of doing that is to have really, really high pressures of oxygen in the bloodstream, dissolved in the bloodstream, being pumped around the body to the organs that you're targeting to get a therapeutic effect. So really, we're quite dismayed when we walk past centres in our malls and shopping centres that offer hyperbaric therapy, and really it's a tiny increase in pressure, often in an inflatable chamber with no extra oxygen. So it's that I can confidently say is essentially a waste of time and money, because there is no known benefit of doing that, and even no real suspected benefit, to be honest.
Sure. Really, it just sounds like that is just going to be more like just a hug from the air rather than an actual therapeutic thing.
There's no question, Bill, that the process of being put into an airtight vessel like that and told that we're going to soak you in extra oxygen and re-energize you, has a certain psychological effect. But it has, when you measure it against real hyperbaric oxygen or only pretending to pump the air in, then it becomes clear it doesn't have any benefit whatsoever.
And with some of the things I've seen in malls, quite frankly, I'm glad they're not using 100% oxygen, because I'm not sure I want most malls having that much pure oxygen pumped into very small places. And I'm sure our local fire departments agree with that.
Oh, they do indeed. And you've put your finger on part of the nub of the problem, which is that there's absolutely, in your country and mine, there's absolutely nothing to stop someone setting up one of these centres with no knowledge whatsoever, or a specialist knowledge of what they're doing, because it's a very safe thing to do. A slightly increased pressure of air is really not going to do the person inside any harm. You don't have a lot of extra oxygen around, so there's no excess fire risk. And so it's a pretty low risk venture. Of course, if you try and start giving people pure oxygen and you've got oxygen bottles around, then a whole lot of safety regulations, quite rightly, come into play, and that's much harder and more expensive to do, so they don't do it.
So I think one of the things that most people who have heard of hyperbarics think of it as something they've seen on TV to treat somebody who's been diving in the ocean and now came up too fast. But we're starting to see more interest in it pop up in Facebook groups and other stroke support forums as folks are looking for it as a treatment for the conditions that result from stroke. So why do folks think that it might benefit stroke patients? What do you think is the theory behind that?
That's a very good question, Bill. And unfortunately, the answer is not, I think, easy to make succinct and complete at the same time. I think at the real basis of it, the idea that we all need oxygen to survive. It's an absolute necessity for life, which means it's a good thing. If it's a good thing, then more of it must be better. So if we present, in the case of stroke, the brain with more oxygen, that must be good for it. Unfortunately, that's a kind of flawed argument because oxygen is actually quite toxic to the body and should be only carefully administered for, specific purposes where you're pretty confident the benefit outweighs the risks. But nevertheless, I think that's at the basis of the belief. And then those hyperbaric practitioners who know and understand hyperbaric oxygen every year eliciting mechanisms by which in specific illnesses that very high pressure of oxygen in the blood may be of benefit. And that's really all about stimulating various enzyme systems and healing processes, and becomes rapidly quite a complex field. But at the base of it, I think it is that it's appealing to think that more oxygen must be better than less. And so when we know that the majority of strokes are ischemic and therefore to do with a lack of blood and therefore lack of oxygen to part of the brain, then surely supplying the brain with more oxygen may help to improve that situation. And it's an appealing idea, certainly in the acute period after a stroke. It's an appealing idea and has been studied quite a bit over the years. The extension of the argument to very many months after the event is a much more difficult line of logic to maintain, and I'm not entirely convinced personally that there's a lot to be gained by using hyperbaric, say 1-2 years after a stroke event.
When we're looking at stroke therapy, a lot of times we break it down into two different phases. There's the initial 24 hours where your emergency physicians are trying to decide this is ischemic instead of hemorrhagic. So if it's ischemic, then we want to do TPA medication to bust the clot, or maybe we want to run the catheter up through the thigh and physically remove the clot. And how do we prevent the brain from suffering more damage? And we may have neurons that are sort of on the edge of dying off at that point, as opposed to the long-term chronic recovery that we normally treat through physical therapy and occupational therapy and speech therapy of trying to engage neuroplasticity. So it sounds like some of the hyperbaric theory might make some more sense in that initial phase. Does the research support that?
That would certainly be my view, that there seems a lot more to be gained from hyperbaric in the early phase. And you're very, well stated the two main acute therapies that are available. Clearly, you've got to support people's, airway and breathing and, circulation. Otherwise, all else is lost. Yes, you very well described the two acute treatments specific to stroke, both of which have been tremendously successful in reducing long-term harm. And it's very tempting to think that hyperbaric might have a role to play in that really hyperacute period. As you and your listeners are probably aware, Bill, there's a very tight time window to remove the clots physically, and a slightly less tight but still very tight window for delivering the drugs and hoping that they'll be effective, which doesn't leave much time in the process to think where we're going to squeeze in hyperbaric oxygen. And that is probably the biggest challenge for finding the right place, if it is going to work, to administer it. Most of the research is before the advent of the physical removal of clots, and so it's quite difficult to interpret now in the light of that change in practice. To me, the great hope of hyperbaric oxygen in this context and similar is that one of the problems with re-establishing blood flow after an event like this is that the newly established blood flow can cause further damage as well as reoxygenating the tissues. And that's usually called a ischemia reperfusion injury. And it's to do with the way in which the blood vessel that's had no blow through it has been damaged by that lack of blood flow. And the re-establishment of blood flow through it recognizes through various chemicals released by the damaged lining of the blood vessel, and that can cause more little clots to form, and you get a drop-off in the function, in this case of the brain. And hyperbaric oxygen is very good at reducing that level of damage when you reperfuse previously ischemic tissue. When the brain is short of oxygen and a stroke is caused, as you quite rightly suggested, there are some areas of the brain which are unfortunately dead and probably and not recoverable. But there are some areas that are just very sick but potentially recoverable. And oxygen may prevent the further damage that sometimes comes from re-establishing the blood flow. How we get the oxygen there at the right time is as much a logistic issue as a problem in proving that hyperbaric has a place. Maybe a clearer way of putting it for me is that we know that the body has lots of defenses against the viability of tissues being threatened by lack of oxygen. And a number of chemical changes are induced that try and protect the tissues, in this case, of course, the brain, from further damage. And if the blood flow is restored rapidly, then those defenses can have helped the brain survive a little longer. Paradoxically, it turns out that another way to improve those defense mechanisms is to give too much oxygen, that is hyperbaric oxygen. So while on the face of it, the re-establishment of the blood flow and the oxygen that it brings can be damaging after an initial injury, the using of very high doses of oxygen using hyperbaric oxygen chambers can actually protect you against the poisonous effects of the re-establishment of the blood flow, which is kind of paradoxical, and many physicians not familiar with hyperbaric oxygen therapy can find that challenging. But biochemically speaking, there's no doubt that hyperbaric oxygen has this characteristic. That is not the same as saying, unfortunately, that I know in my heart that in the clinical situation it makes a positive difference. And that's the leap we have yet to make, I'm afraid.
So it sounds like the theory there is sound, but the research hasn't really evaluated sort of a best practice to put that into place or demonstrated that necessarily effectiveness.
Absolutely correct. And as I think I mentioned, the unfortunate thing is that when the interest was at its height was before the era of removing the blood clot physically, which meant that since those studies have been done, the treatment has pretty radically changed. And if we're going to pay much attention to research in hyperbaric, we really have to do it again in the context of the best modern treatment to be sure of its place. And it also must be said that when those studies were done, there wasn't a great deal of benefit demonstrated in the 3 randomized trials done on relatively acute stroke patients. There was very, very little sign of benefit. People were quite disappointed in that. I think the main problem was that in those trials, it probably wasn't given urgently enough. That's not surprising because it's very difficult to convince all those in charge of looking after stroke patients that this is something that has to be done right now. Otherwise, we lose the opportunity. And there are other things, to be done in the acute care. So it's a very difficult, acute treatment is very difficult to give if you're talking about locking someone in away from the rest of their care for a couple of hours in a hyperbaric chamber. most of those trials were done days or weeks after the event, which suggests to me that it's too late to be of any great effectiveness to the individual patient.
So in addition to the logistics of it, especially in those short time frames, the idea is also when you're trying to do the research of securing informed consent from all the appropriate parties and taking care of the logistics becomes really challenging in that first 24 hours.
It is challenging, but there's one more problem, and that is hyperbaric physicians own that chamber, looking for people they believe can benefit from it. And we have to go to our stroke colleagues, our neurology colleagues and others, and convince them to hand those acutely unwell people over to us to do this treatment, which to them is somewhat mysterious, somewhat paradoxical, and certainly has a long history of being misused by some groups of physicians as well as non-physicians. And so it has a fairly colourful reputation amongst other physicians. Whereas when the clot-busting drugs came along, said we can break up this clot and re-establish blood flow, that makes sense to all physicians. When someone comes along and says, I've got this fancy equipment, I can put a wire up here and a cage and I can drag that clot out, that makes a lot of sense, and everybody's on board immediately with the idea. So part of the reason we haven't done the kind of trials we need to do to establish the true place of hyperbaric oxygen, if any, in this situation, is because it's a much harder thing to convince our colleagues is worth their time and effort when they have these other two things that have clearly made such a large benefit. So I think we're on the back foot here, and there are good reasons for that. I'm not saying it's not rational, but it makes it difficult for us to mount those trials. Now, I personally have tried hard to get a randomized trial of the early intervention with hyperbaric in the group where it's decided the physical removal is not practical or timely, and that maybe those people could come to the chamber instead with clot-busting drugs continuing in the chamber. We have big chambers where we can give all these complex medical treatments uninterrupted, but the fact is that the clot retrieval and the clot-busting drugs are so successful that it's difficult to convince the stroke people that they need another quite invasive, in terms of time, treatment added on top, and they're really not terribly interested, to be honest. And I suspect that attitude is probably widespread. And to be honest, I understand it well. They're as fearful as anybody else would be that the net result may be more harm than good, particularly if we were to interrupt the well-established early treatment pathways.
So those are definitely some challenges with that immersion situation. A lot of folks who may have had their stroke, 6 months, a year, 3 years ago, 5 years ago, 10 years ago, you hear about hyperbarics and wonder, can this help me regain movement or help me solve my cognitive challenges, help me learn to speak again by addressing some of the damage that resulted in aphasia? And so we hear about folks who want to explore this who are in a more chronic situation. And it sounds like that's where a lot of the attention is in more of the popular stroke culture, but it also sounds like the research is really even more negative on that. Is that true?
You're absolutely right. There's an awful lot of attention in this area. And, I should say at the outset, before I get carried away with myself, I recognise, of course, what a huge thing it would be if a pretty simple and relatively harmless treatment like a course of hyperbaric oxygen could really positively affect people, well after the event, as you described. I mean, what a wonderful thing that would be. And the idea that people who run hyperbaric chambers are opposed to treatment, although they know it works, they're really not interested, which is a criticism that's frequently levelled at us. It is problematic. So I want to say at the outset, I wish it did work. I really do. I mean, what a wonderful career it would be helping people, who looked as though they were going to be permanently more disabled and as you say, with both physical and cognitive problems, and that to positively influence that would be such a worthwhile thing. So that's my preamble to answering your question, which is unfortunately I'm very much of the not convinced here of the evidence. The idea is that even long periods of time after the original stroke event, there may be parts of the brain around the stroke area that are still resuscitatable with the right treatment, and that a course of oxygen will re-establish new blood vessels that will wake up these sleeping tissues and thus improve the clinical and cognitive state of people. It has, to me, a very thin basis of fact in good physiology and science and indeed in clinical evidence that is true. Doesn't mean it's not true, but I don't see much evidence that it is true. And the proof of the pudding, as with so many things, is in actually treating people who are in that situation and carefully comparing those that you give some hyperbaric oxygen to those that you only pretend to give hyperbaric oxygen to, and carefully, measuring how they are after the treatment. And that's only been done once or twice. One very well-known study purports to test in a randomized way the effect of hyperbaric, but it's unconvincing. And it's unconvincing because they compared giving hyperbaric to a group of patients to another group of patients who they told they could not help and sent home. Now, my concept of what is happening here is that the ritual of hyperbaric, it's a daily treatment for some time, lots of highly motivated people ensuring all other treatment is delivered as it should be, people displaying care and support, including your fellow patients in the chamber. This is an environment in which there is a lot of strong positivity. And to me, it's not surprising that when you measure subtle cognitive outcomes, you find small improvements in that group. It is absolutely possible it represents a real therapeutic effect. But we can't be sure unless we compare those results against a group of people who have been convinced they're getting hyperbaric oxygen, but in fact not being treated. And unfortunately, there are a number of groups, particularly a group in Israel, but many others, both in the United States and elsewhere, who say we can't do that because as soon as you put someone in a chamber, whatever you do to them is an effective treatment. And that's why when you test a lot of things, particularly chronic neurological problems, in a proper randomized double-blinded study where no one knows who's getting which treatment until the keys are unlocked at the end of the trial. There's a lot of negative studies that way where both sides, both groups show mild improvements that are usually fairly temporary. I think that in the best trials that have been done in chronic stroke patients, we are measuring a placebo effect. Now, I might be wrong. I'm quite happy to be proved wrong. I hope I've become proved wrong. But until we do the right studies, I think we simply don't know at this point.
So much as I talk with other survivors and other folks in the field, so much of your recovery is dependent on your belief about your recovery, how well if you think there's nothing that can be done and you're not going to recover, you know what? You're right. You're not going to recover.
I agree. And into this volatile, highly dependent situation, I mean, highly dependent on your motivation and also the motivations of others around you, then it's very tricky to measure something that you're only claiming a fairly modest improvement from. Now, I mean, if hyperbaric was a miracle cure and made huge differences to how people both thought and how they moved, then it would be hard to deny that that was a real benefit. But these changes reported are pretty subtle and could even be the result of multiple testing. That is, tend to get better if you do the same test over and over again. Mm-hmm. So I'm a strong advocate for proper randomized double-blinded trials where the occupants of the chamber in both groups are convinced they got real hyperbaric oxygen. And if we don't see differences in that kind of trial, then I'm afraid I would ascribe the effect to a participation or placebo, sometimes it's called, but exactly the kind of motivating treatment that you described, Bill, and that's unfortunate but true for other chronic neurological illnesses like mild post-concussion syndromes, PTSD, and autism, cerebral palsy, all of which have had those trials applied. Unfortunately, hyperbarics failed to show any significant benefit over the sham treatment, over the pretend treatment. Now, that hasn't been done with stroke yet, so the question is still open. We have two camps. One says that's the best trial we can do. You can't, because even just locking the door of a hyperbaric chamber somehow has an effect on these people. There's no such thing as a sham treatment. We can't do it. And that's an unfortunate impasse, because when we do the proper trial, in the face of that argument, when we do a proper controlled trial in which we pretend that people are getting hyperbaric, the response is always, oh yes, but you actually gave them a little bit extra pressure and a little bit of extra oxygen. And, just being pressurized in the chamber is effective. And it's a kind of circular and impossible to resolve argument. I think I should repeat, it's possible that I'm wrong. Absolutely. And until we do the right experiments, I speak, fully aware that I'm using the best interpretation I can of poor data. And I suspect there's no real effect of hyperbaric in this situation, but I'm not ruling it out. Unlike those strong proponents of hyperbaric in this situation who say we have proven it works, there's no doubt. I'm not that sure, and we really need to do a trial that both sides of the argument agree is a fair test. And unfortunately, we've been unable thus far to come to that understanding between us. We are making some progress, and there are some possibilities. One possibility is that you do the trial at relatively high altitude. Salt Lake City is a place that comes to mind where they've done some very interesting work. And having a chamber at altitude means that you can do a pretend treatment where all you do is compress the chamber to 1 atmosphere at sea level. And that's enough to fool anybody inside into thinking they've got real high pressure treatment. But you're not giving them anything except normal air at 1 atmosphere. So, I would accept that as a good pretend treatment. And we're just trying to convince some of our colleagues who hold the opposite view that that would be an acceptable way of shamming the treatment. But we haven't got a definitive answer yet.
Gotcha. But something like that would at least get us, even if they don't agree that it's 100% perfect way to do a sham treatment, you're getting a lot closer and much more reliable data that way, at least.
We know that we can convince both groups that they're getting real treatment using that, because the people in Denver have proven that even people with diving and hyperbaric experience who are inside the chamber can't tell which group they're in. So we're happy about that. The fly in the ointment is that before we do any experiment like that, we've got to get a solid statement from our colleagues who disagree with us that they will accept that is truly not an effective treatment. It's really just returning people to as if they lived in Seattle instead of Denver. So we're trying to make progress on that to break this deadlock. It's a great shame, because in the meantime, it's possible, I don't think it's likely, but it's possible that an effective treatment is not as widely known as it should be. It's also possible that a lot of people are spending a lot of money having a treatment which is actually useless. So for both of those reasons, we have quite a lot riding on getting these things done, these experiments done.
So in the meantime, for those folks who are spending money on a treatment that may in fact be useless for them, is there any additional risk from undergoing that treatment to the brain or other neurological functions, or is it really just a financial risk for them?
Well, I think the risk is mainly financial, and there's no doubt that there are a lot of people spending a lot of money on this treatment around the world. There are other downsides apart from the financial. It's certainly very time-consuming, and one might argue that for some people, in some circumstances, that's taking time away from what could be more effective therapy applied to them, physical therapy, for example. So if you have a 2-hour treatment every day, it probably takes 3 hours to turn you around through the facility, plus whatever your travelling time was to get there and back. So that's taking a big chunk out of your day, which maybe would be better spent doing something else. And then there are some risks of the oxygen treatment itself. Now, they're pretty mild, and I don't think they're a strong reason to avoid hyperbaric treatment. But nevertheless, they're not zero risks. One can damage the middle ear from the change in pressure. So most of the listeners will be familiar with the feeling of the ears needing to be popped when they're in an aeroplane descending to land. That's an effect of the change in pressure in the cabin. And at the start of every hyperbaric treatment, you get the same feeling, and you really need to equalize the pressure inside your ear as it is on the outside. And if you can't do that, you can damage your eardrum. You can cause holes in the eardrum and infections. So it's uncomfortable and unpleasant, but it's not a terrible complication. It will heal up, but it's not pleasant. A long period of hyperbaric oxygen can give you a temporary increase in short-sightedness, which can last several weeks, but nevertheless will also get better. They're the common things, and they're fairly minor. The oxygen can be incompatible with some anti-cancer treatments, so it's very important that the doctor gets a full medication history to make sure there's no interaction between oxygen and drugs. But apart from that, we find the main side effect is boredom. So we try and provide a bit of entertainment inside with videos and music playing and so forth. So I think an argument can be made, Bill, at the end of all that, to say, well, it's probably not going to do me any harm. I'd like to try it. I've weighed up the cost of that. I go in with my eyes open and hope in my heart, and at least I'm pretty confident that it'd be very unlucky to have any health setbacks from that decision.
And we've talked a lot about how it doesn't work for stroke, and it doesn't work for this, and it doesn't work for this, according to the research, or rather, not that it doesn't work, but we don't have evidence that it does work. There are lots of other fields where hyperbaric medicine does benefit patients.
Oh, absolutely. And, our bread and butter is two main indications. There's a wealth of evidence, and every hyperbaric practitioner would feel very positively about treating people who have been cured of cancer using radiation therapy. But for an unfortunate small minority, the radiation therapy causes problems in the non-cancer tissue that can be quite debilitating and at times even life-threatening. And hyperbaric is really the only proven therapy to physically reverse the changes of the radiotherapy damage. So we treat a lot of people who've had radiation in the head and neck for various cancers, in the pelvis for prostate cancer, rectal cancer, cervical cancer. And we reckon that a good 2/3 of the people we are asked to help get considerably improved by a course of hyperbaric oxygen. Sometimes the second course reinforces that. So that's very rewarding, and unlike stroke, unfortunately, that we've been talking about, backed up by quite a lot of high-level evidence that suggests hyperbaric is truly effective against a pretend treatment, and we're confident in what we're doing in that area. And similarly, in the treatment of people living with diabetes who have ulcers, usually on their lower limbs or feet, there's a similar wealth of good clinical evidence that we can help those ulcers heal up over a period of time and make those people's lives a lot less complicated and reduce the rate of amputations required. So that's of great value to them. And so those are the two really rewarding things we treat every day in very high numbers, Bill. There are a few other things, people dying of gas gangrene or very nasty flesh-eating bacteria that's popularly known. Hyperbaric seems to be associated with an improvement in the chance of surviving with all your limbs from that. Carbon monoxide poisoning can, as I'm sure you're aware, be a fatal exposure, but people can be quite seriously damaged by a less than fatal dose of carbon monoxide, and we believe hyperbaric can prevent some of the late changes as a result of carbon monoxide poisoning. And finally, less well proven perhaps than what I've already talked about, but still something we're reasonably confident about, and that is we can improve the health of flaps and grafts that people may have had for various plastic surgery operations where the flap or the graft looks threatened, looks like it may not be successful. We are happy to employ the hyperbaric to try and rescue those threatened tissues by keeping them full of oxygen. So I think that's a rundown on the things that we're pretty sure about. Patients that we're less than that sure about that are under investigation. We're currently involved in a big investigation of people with sudden hearing loss, which looks very promising. There are a group of people who lose hearing, usually in one ear, suddenly without apparent cause. No cause can be found. And in those people, it looks like hyperbaric can restore quite a lot of the hearing, I should say, in the affected ear. So that's an investigational indication, an example of the kind of thing we're working on at the moment.
That's great. There's a lot of stuff out there where it has been demonstrated to be effective, but just hasn't been demonstrated for the neurological conditions resulting from stroke at this point.
Unfortunately true. And Bill, I think that's a very good characterization. It is throughout the history of hyperbaric medicine, people have been highly attracted to treating chronic, usually stable brain injury conditions because we have very little effective curative therapies. When you think about things like cerebral palsy or people have difficulty functioning because they're on the extreme end of the autism spectrum, people with multiple sclerosis, there's always been a lot of interest in applying hyperbaric to all these chronic neurologic conditions. And I'm afraid to say that hyperbaric has not turned out to be definitively useful for any of those, unfortunately.
If folks want to learn more about hyperbaric oxygen therapy or follow your research, where should they go?
Okay, well, we have a site that, along with some help from a lot of colleagues of mine, we maintain a watching brief on the evidence as it emerges, and that's called HBO Evidence. If people search in their favourite browser using HBO Evidence, they'll find us. It's through the University of New South Wales, tried enough to host our wiki site there, and we can get folks to communicate with us over that, ask us questions, and we can get fellow workers from around the world to. There's an account of what hyperbaric medicine is and how we use it, and also an account of a kind of trial methodology that we've been discussing today. So people might be interested in that. Also, when asked by non-hyperbaric physicians where they can get a little rundown on what it is we do, there's a very good article in a site called Medical News Today, all one word, where if you get onto medicalnewstoday.com and search for hyperbaric, there's a very nice piece by a journalist there who's really got to the nub of what it is and how it's used these days. So that might be of interest.
We'll have all those links available over at strokecast.com/hyperbarics. So, Mike, thank you so much for joining me this week on Strokecast. This has been really informative and I hope really helpful to the audience.
Well, that's very kind. Thanks, Bill. And, it's been a great pleasure to talk to you. I hope I haven't made things less clear than they were before I started.
Things might be a little bit less clear for some folks, but a heck of a lot more accurate.
Yes, unfortunately, there's very few certainties in life, aren't there, Bill? And unfortunately, we are not there with the intersection of hyperbaric and stroke. I wish I had more positive things to say, but we're working on it. And who knows, one day maybe we can talk again and things will have moved on.
I look forward to it. And that brings us to our hack of the week. Last week, I talked about cutting meat at a restaurant. The upshot was don't. This week, let's talk about doing the same thing at home where you may not have a kitchen staff. Sure, at home you can just pick up the hunk of meat with your hands, but sometimes you still want to slice it for some reason. I use a vertigrip knife. It's designed for folks with use of one hand. I hold it in my fist, rock it against the meat, and it cuts right through. It doesn't require you to brace what you're cutting with a fork. For a $14 gadget, it actually works really well. I'll go ahead and post a link to the Amazon page over at strokecast.com/hyperbaric. In a program note, a few months back, German podcaster, magician, and mindset expert Victoria Mavis joined me to talk about the intersection between public speaking and magic on my other podcast, 2-Minute Talk Tips. You can find that interview with Victoria over at 2minutetalktips.com/magic. During December, I had the pleasure of appearing on her show, Pure Mind Magic. We talked about speaking, sure, but much of the conversation was about my stroke story and the power of mindset in recovery, which is why I'm talking about it here. You can listen to that episode over at strokecast.com/hyperbaric or subscribe for free to the Pure Mind Magic podcast in your favorite podcast app. So have you tried hyperbaric oxygen therapy? Let us know about it in the comments over at strokecast.com/hyperbaric. Try picking up a vertigrip knife if you need to cut things one-handed. Share this episode with someone in your circle who is interested in alternative therapies with the link strokecast.com/hyperbaric. And of course, as always, don't get best, get better. Thanks a lot. I'm Bill Monroe, and I'll talk to you next week.
The Strokecast, Bill Monroe, and Bill's guests provide general information and entertainment, not medical advice. Please do not make any changes to your treatment plan or the execution of your treatment plan without first consulting your personal doctor or medical team. The Strokecast is a proud production of the Currently Speaking Podcast Network.